Hello, everyone, and thank you for joining us again for a second attempt at this. I'm hoping that my internet doesn't glitch like earlier. So today with us, we have Carrie Benton, who is muted again. Thanks a lot. You can unmute. And also we have Bev, who is a long-term care facility nurse and also a long-term friend of Carrie. She's on here just to make sure that if I start to glitch again, then Carrie isn't left in silence, and so they can, discuss as well. So we have a little more control, hopefully, on what's going on. So as I was trying to say earlier today, when we attempted this in the afternoon, this particular episode of Beyond the Data is kind of a special edition type thing because yesterday morning, the Dr. Vanderhoff and Dr. Thomas had a press conference for ODH talking about the scary Delta variant and vaccinations and that kind of stuff. And when I watched it, it was pretty epic. It was a little over an hour, I think about an hour and 15 minutes press conference with questions. And yeah, it was something else. So I decided I should definitely refute some of the stuff that they were saying. And so I've got Carrie and Bev here who have not seen the press conference, have not seen what some of the things said are. So they're going to kind of be reacting in real time, and we'll discuss a little bit of the data and some of the lab science as well with Carrie. But without further ado, I think we'll get back into, hopefully, I'm not glitching, right?
No.
I'm smooth. I'm good. All right. So I guess late night things are the way to go. I kind of split these videos into kind of topics. And the first topic I wanted to play these videos for were discussions about the Delta variant itself. So here we go with our very first comment. If I find it here. There.
With the highly contagious Delta variant now spreading across the United States, it's more important than ever that people make the choice to be vaccinated, because it's clear that those who are vaccinated are less likely to be hospitalized, suffer from multi-system inflammatory syndrome, become a long hauler, or die from COVID-19.
So there you go. So now we know Delta variant is super contagious, right? We got to be really wary about the super contagious Delta variant and Miss C and all these horrible things, right?
Because Bill, I said so.
Hold on to that thought. Hold on to that thought, Bev. We're going to get there at some point. We will get there. But so that's what they started out this whole press conference talking about. They started talking about, that we need to be afraid of this super contagious strain, and that the vaccinated are less likely to die. Now, I actually posted on my page, I think it was yesterday or 2 days ago, some data from the UK. Where they actually are putting out a lot of information. Unfortunately, since I focus so much on Ohio, I really don't know all the details, all the ins and outs of how they play the games. Because I know Ohio's games. I know about the probables. I know about how the testing works. I know all of these things, but I do not know it for the UK. But recently, I was shown documents that the UK has been putting out, I believe every week, huge amounts of data. And one of the things that was most interesting to me is this. This is part of a table in that document. And at the bottom, you can see where I outlined in red, that box are deaths within 28 days of a positive specimen date. Again, the UK actually limited how far out from a positive specimen, a person could be considered a COVID death. So in Ohio, we can have COVID deaths that happen over a year after having a positive COVID test, and that still counts as a COVID death, not in the UK. And one of the things that they did that's really interesting is that they broke it down by the vaccination status, and not just vaccinated versus not vaccinated, but also what part of the process they were in terms of vaccination. So you have those within 21 days of the first dose, those greater than 21 days after the second dose, and those who have received 2 doses, as well as unvaccinated. Now, right here, what do you guys see there with those numbers that I boxed in?
So we have more deaths that have been vaccinated, that have received 2 doses than the unvaccinated.
Right.
Yep. So right there, we have Dr. Vanderhoff there saying, well, the Delta variant is associated with more hospitalizations and more deaths. Now, in this document, they do show that there were more hospitalizations associated with the unvaccinated. But this is where part of the problem comes in terms of I just don't know the UK data sufficiently. This is going all the way back to February 2021. So what are we looking at in terms of the number of unvaccinated days that we're looking at? How many vaccinated days are we looking at? All of those issues. How many vaccinated versus unvaccinated had hospitalizations or deaths? Either way you look at it, though, when we see more deaths in the vaccinated, in the fully vaccinated, not just 1 dose vaccinated, we're talking 2 dose vaccinated individuals. We have more deaths there than we have deaths in unvaccinated individuals, going all the way back to February 2021 in the UK. So we have Dr. Vanderhoff saying this, that it's just so terrible. Now, I don't know, that doesn't seem to be the case. So the next clip here is, again, about the Delta variant. We've learned, it's super dangerous. It leads to more hospitalizations, more death. That is his claim, his next claim in the press conference.
Delta is highly contagious, and it spreads exponentially fast almost anywhere it has gone. Estimates are that it's about 50% more contagious than Alpha, or the B.1.1.7 so-called UK variant, which itself was 50% more contagious than the variant which caused our winter surge. As a result, the Delta variant is moving rapidly to replace B.1.1.7 or the Alpha variant as our dominant form of COVID-19.
So when he says rapidly moving to replace our, does he mean our as in Ohio, our as in the nation, our as in the world? Like, I guess it's how you interpret that, because
Yep. So I believe in that particular clip, he was referring specifically to Ohio, or definitely the U.S. But the interesting thing there that I found interesting in that particular clip is what he said about it was so contagious, right, that it quickly overtakes the other variants, right? And that it's 50% more contagious than the B.1.1.7. Now, when did the B.1.1.7 come through? It came through in Ohio sometime around May-ish, right? That's when it became the dominant one. And what's the other thing he said in that clip? He said that the B.1.1.7 itself was 50% more contagious than what was the dominant strain during our winter surge. So
B.1.1.7 is not Delta.
No. So B117 is not Delta. Delta
Right.
is B617.2.
1617.2.
Yeah. So what he was saying, and I wish I had a pointer here. I don't know how to do that here, but if I had a pointer here right now, he's talking about that we now are facing the Delta variant and that we need to be scared of the Delta variant because it's 50% more contagious than the B117. The B117 came through in about early May or so. So maybe that's what was going on in that hump on this graph of inpatient daily count. That might be the B117. Let's go with it. Let's say that was B117. Well, then he said, well, the B117 itself was 50% more contagious than the winter surge. And we can see the winter surge on this very, very clearly. We can see that the winter surge was huge, and the B117, when it came through, although 50% more contagious, was not dangerous. And yet they are giving this impression that it is super dangerous, even though that is not what the data was showing us.
So I think there's a difference between contagious and infectious, but
and also virulent.
But does he ever during this, does he quote where he's seeing this from? Because what he's saying is not matching the CDC. So I'm confused.
He brings up the CDC significant amount of times, and I'm definitely interested in. Yes, he does bring that up. They actually, I think I'll be talking about, or I have one of the clips about that. They actually come out and they say that, we get our information from the CDC about what these different strains are doing.
Where?
Oh yes, we'll wait for it. We'll get there. I'm really curious in your response on these ones. So there we have it. We have, first of all, the Delta variant is very dangerous, and you're more likely to die. You're more likely to be hospitalized. But the UK data does not show us that. Well, the second thing he's saying is, it's more contagious. Well, it might be more contagious, but so what? If it's more contagious, that's fine, so long as it doesn't lead to increased disease, which we see that the last one they told us was going to be terrifying. Well, that was a dud. So this is actually kind of the natural way that novel respiratory viruses tend to evolve in populations. They go from highly virulent to more and more contagious and less virulent, because that's the evolutionary advantage they can do. So that's what we have so far in their little story that they gave us yesterday. The next thing to be afraid of is
Delta is a real threat to the unvaccinated, or those who are not yet fully vaccinated. According to the CDC, current data suggests that 99.5% of COVID-19 in the United States has occurred among unvaccinated people. And experience in the UK also suggests that those who are younger than 50 may now be more than twice as likely to be infected. And this
So he did say in the US. He did say that. He didn't say it, which is concerning because he didn't say anything about Ohio, and he brought up the UK. But what about Ohio? He works for Ohio.
Well, no, they actually, so one of the things that he talked about in this press conference, and I'm actually not sure if I brought that clip into this, but he actually, I think I did, or I will have it here. One of the things they talk about is they don't have the data. Actually, I think that is one of the next ones I wanted to show. They don't actually have the data on the Delta variant in Ohio. What they are basing all of their decisions on, all of their data on, is data from peer-reviewed studies. They said there was a recent one in Lancet, but they don't mention who or anything beyond it was in the Lancet or from the CDC. So I was curious there about the whole 99.5% of infections are in the unvaccinated. I mean, that one was an interesting one. I'm quite baffled by that. I mean, what are we actually hearing here? What is going on? Are we talking about 99.5% of total or recent?
Right. And I don't know what that means. Or is it 99.9.5% of a hospital? Is it 99.5 WGAR? I don't know what he's talking about, because that 99 point, again, it's really broad. But when you stop testing vaccinated individuals, unless in certain circumstances, then you're going to have more test specimens of the unvaccinated. So that's going to make sense. That doesn't mean that the others aren't sick. It just means that we don't have the data to show that because we didn't run the test.
Isn't it interesting? Because I had the same thought when I heard that as well, where I'm like, okay, well, what sample are we looking at here? If we're talking about 99.5% of the cases through the entire pandemic are in the unvaccinated, well, duh, because most of the cases happen. Is that what we're talking about? I don't know.
And he never did clarify?
I don't believe so. I didn't hear anything in this that I at least understood. It might be worth watching it again, but I didn't catch where he said.
I could watch that.
But your already vaccinated individuals would somewhat be your control group to test the new cases against. So if you don't have a control group, what's the point of testing the new people in the first place?
Well, if they're sick, if they're coming in with symptoms, so that would be for a vaccinated person, a breakthrough case, or what we call a vaccine escape. So in those two situations, and Ohio has very strict guidelines on when we can test vaccinated people.
When can you then? Because I know in the facilities, you're not tested at all if you're fully vaccinated, period.
Right. So you have to be symptomatic. And if it's treatment failure, vaccine breakthrough, or vaccine escape, any of those things expected, then you can test. But you can't, whereas if an unvaccinated patient were to come in, the first thing that they're going to be tested for, if you have those symptoms, is COVID-19.
But at the same time, a common cold can mimic some of the same symptoms that COVID does.
Can.
So why are you not testing them even if they're showing just the slightest symptoms of a common cold, thinking that, oh, I'm fully vaccinated, so this can't be COVID, it's just the common cold.
Right. And we do run into the issue, which we'll get into, is a couple of the variants actually evade our testing because we're looking at specific proteins. And I don't know if there's a clip that even matches that, because I haven't got to hear this wonderful, joyous individual speak.
I don't know if I have the clip about him describing the testing situation. So if you find a point during this whole thing that you want to talk about how we do the genome sequencing and that kind of stuff,
try
whenever you want.
Okay. So we have another clip?
Yes, I believe we do. What's my next one here? This is just basically reiterating.
Is there a fun clip? Please tell me you did a fun clip.
I did. I actually have two fun clips. So if you stick with us to the end, I do have two fun clips, and you know what one of my fun clips was, because
I kind of gather because I read Facebook comments across social media, but I don't know for sure. So I can't wait to hear.
You'll enjoy it. Okay. You'll enjoy it. It made my day. It made my day. But here we go, back to the Delta variant.
According to a recent Lancet study, Delta is much more likely to cause someone to be hospitalized if they're unvaccinated than the Alpha variant was. So the reality is we now have two Ohio's, an Ohio that is vaccinated and protected on the one hand, and an Ohio that is unvaccinated and vulnerable to Delta on the other.
There's so much wrong with that, right? I mean,
Yes.
First of all, we've just kind of gone over the whole business of the hospitalization, because I do know that I've heard from several people working in hospitals that they have definitely pulled back on testing people who are vaccinated. They definitely do not test vaccinated people if they are not showing any symptoms. If you're just going in for a procedure, they are not testing those people. And yet they continue to test those who do not have symptoms or going in for a regular procedure who are not vaccinated. So, of course, it looks like there are more hospitalizations. And then, of course, that fantastic line that did get spread over mainstream media and social media yesterday about the two Ohio's, one that is vaccinated and okay and protected, and the other that is unvaccinated and at risk from the Delta variant. And of course, there's always the third option of individuals who had it and who have natural immunity and are unvaccinated. They
And that
are
was
not
right. Well, that was going to be my question was what I don't think she realizes. Okay, we can see you, Bev.
I can't help it. You kind of ambushed me. My power.
Okay. Oh. So if your power's out, then chances are Kathrynn's internet's not going to be too far behind.
No,
I do have a generator,
my
so we're
battery was
good.
low on the phone. I had
okay.
an outlet.
So the two Ohio's is concerning because not one point did they mention natural immunity, and we know just like if we have a cold, it's a strain of coronavirus, so we have some type of antibodies. It doesn't mean that it will help if there's a horrible strain or even a norovirus or an influenza. Obviously it's not, but I think that two Ohio's is a real big stretch. That's very divisive. This just causes more division that we don't need. I've never seen anything treated like this. It's kind of sad. I'm really disappointed. That's not good leadership. Was he elected, or was he just did they draw his name out of a hat? How did he get his job?
I don't. DeWine chose him.
Oh, shocker.
We had Amy Acton for a while, and of course she vanished. And then they installed. They had an interim one who was a lawyer, and a compliance lawyer. I mean, really, really fun stuff. And then Governor DeWine installed Stephanie McLeod, who
for ODH.
For ODH. Again, she's a lawyer. She had been running the BWC, Bureau of Workers' Compensation.
And a journalist. She's also a journalist because this past 18 months has proven so much integrity there.
Wow, I didn't know that. That's interesting. But in any case, so she was put in as the director of ODH. She has no medical experience, and Governor DeWine did get quite a bit of flack for that. But nobody wanted to take on that job. And so I guess he had some arrangement with Dr. Vanderhoff to allow him to be not the director of ODH and have all of that responsibility. Instead, he gets the sweet position of the chief medical officer of ODH. So I don't know what his salary is, but he doesn't actually have any of the responsibility of the director of health. But he gets to tell us these things. And I can tell you not once in this entire press conference that they gave yesterday, not once was natural immunity ever mentioned. Not once. Not for any reason.
That's disheartening because that's exactly what science is built on when it comes to viruses and disease. So that's unfortunate for Ohio.
Very much so. So the next one is definitely for you, Carrie. This one, the reporters were asking some good questions. Some very good questions.
I might have to take back my journalist comment then.
Oh, you might need to, because
Okay.
I really have to salute some of these. And also Dr. Thomas. I mean, I definitely have not had very many nice things to say about Dr. Thomas, but I mean, he said some good things this time around, and it was an interesting contrast with Dr. Vanderhoff. But for now, here's a great question.
Hi, Dr. Vanderhoff. Thanks for taking my question. So we were told the state does not track the number of breakthrough hospitalizations or deaths that come specifically from the Delta variant. So how do health officials know the efficacy rate of the existing COVID-19 vaccines in fighting that variant?
Sure, that's a really, really good question. And let me break it down in a number of ways. One, perhaps the most important way that we monitor efficacy are through published studies that are designed to give us an understanding of how well the vaccine is working. And those are iterative. They come in, over time. And we've had recent published studies that have looked at the Pfizer vaccine and the Johnson & Johnson vaccine, both of which have been very, very encouraging. There's an ongoing study right now with Moderna, but since it is essentially the same thing as the Pfizer vaccine, I think most in the medical and scientific community, really ascribe whatever is seen with Pfizer to Moderna. It certainly played out that way over time. There's a second mechanism, though, and that is that the FDA and the CDC together do ongoing concurrent monitoring of the vaccines. And a part of that concurrent monitoring, of course, also involves the efficacy of the vaccines. And then the final piece of that is we can look at overall vaccine breakthrough rates. As you know, our vaccine breakthrough rates in terms of breakthrough hospitalizations, breakthrough deaths have been vanishingly low. And that has continued on a national basis, even now when nationally Delta is the dominant virus. And here in Ohio, where it is emerging as the dominant virus. So those patterns together, those three sources of information give us, I think, a very high degree of confidence that this vaccine, this set of vaccines that we have and the Delta variant are a good combination. But it's certainly something we pay a lot of attention
to. So we do not have there's no published studies for an mRNA vaccine because we haven't used it in a real world situation. We've used it for target tumors. We've used it for animals, different strains. We've tried them and they've always failed every single time. We've never gotten, you're making my eye twitch. But so what is he talking about that we use that? No, the way that you historically have monitored breakthrough hospitalization and death is you have all of your known variables and then you have your unknown and you limit. So if you come in with these symptoms, I don't care if you have the vaccine or not. If it looks like a duck, walks like a duck, talks like a duck, you have to test it and see if it's a duck, regardless of vaccination status. Because it is a vaccine, it is not an immunization. So when we have two separate playing fields or two separate sets of criteria of how to test, then we no longer have a level playing field. So can he cite that source?
He has not. No, not to my knowledge. I do believe, though, when I look through all of the, when I do see things like that, where I hear that and they're like, oh, it's really terrible, and or rather that the vaccine has high efficacy and all those things. One of the things that I had noticed in the past is the big studies that they have done on that, they do not take into account natural seasonal variations. So the natural seasonal variation was that we had a large increase in cases, a large number of cases that occurred in November and December.
Oh,
but
flu
the first
season, cool.
It's cool, flu season, right? So we had huge numbers of people getting ill and developing natural immunity while unvaccinated. And so you have these large numbers of unvaccinated people who got the virus during this, peak season. And then as the season was ending, you had you started getting some people who get vaccinated. But it took until January until we had any fully vaccinated people. And then, of course, you have to even go even further than that to get 2 weeks after full vaccination. So we're now talking somewhere in the range of February that we had even in the thousands of people fully vaccinated and 2 weeks past. So what you're looking at is you're having the unvaccinated days are all collected in the middle of seasonal of the seasonal peak, while the vaccinated days exist outside that range. They exist when the epidemic was already on the waning side. So you're comparing people who were getting sick during the high epidemic with people who were getting sick after the high epidemic, and you're saying that the difference between the two is not the season, but rather the vaccine.
Because there are a variable of the season. So when it's you have to.
Yep.
That's just not good science. In Ohio, there's 261 vaccines that are in trial, some type of, if it's preclinical or, we have 3 that are in phase 3 trials, but there were several Ohioans. We had one of the largest enrollment of Ohioans that went into some clinical trial for a vaccine. We had a lot. So they, those ones would have been a little bit earlier. And we know that depending on which trial it was, they either monitored for 7 days after or 14 days after. That was it. There was no trial that monitored beyond 14 days after. And it was like a call-in where you filled out a survey, depending on which one it was. They didn't have a face-to-face unless there was an issue. If there was an adverse reaction or an undesirable reaction, then depending on what it was, they would have a face-to-face. But once they got their second shot, they weren't seen again unless there was an issue. So,
and they couldn't deny it.
Right. And so, but it was, like I said, by the 14-day mark, they weren't looking at that anymore. And so that's how they were able to meet their endpoint so quickly to get that EUA. And I don't think that people are really grasping that, but we had a lot of people, that a considerable amount of number when you look at other states of similar size and population, that had vaccines before they were eligible through the governor for the vaccine. And I'm not sure, being a clinical trial, unless they unblind all of them, some were, some weren't, if those are even counting towards our vaccinated total.
Probably, because one thing I did notice is it totally weirded me out with the vaccine data. So they do, in the state of Ohio, they play the same games with reported and assigned dates.
Mm-hmm.
As they do with, and there were of newly worded vaccinations that suddenly they were being filled in December and January.
Okay.
Newly reported.
And they should have went.
Was in May or June.
They should, but they actually should have went back. I want to say it was July of last year when the trials. I'm sorry, Kathryn, I can't hear you. I'm losing you again. She frozen?
Yeah.
Yeah. But I don't know if they were in. There it is. I don't know if they were enrolling in July or if they were beginning in July. And it's two of them are ones that are not out yet. You know, they're not available in the U.S. One being the AstraZeneca. So I'm not sure where they were at. So or how much of those numbers are included. So it would be interesting to know. It looks like to me when I look at the dashboard that the state data is the total population and not the eligible population. I mean, we should be taking, 0 to 10 or 0 to 12, I'm sorry, out of that completely.
So they did try to do that. They did do that in that press conference. They were trying to, boost the sounds of the numbers in this press conference. I do not have that clip, but they were, boosting the sound of how many. They're like, well, actually, we're somewhere at like 68% of eligible Ohioans over the age of, it was some really random number. That they chose, which always makes me kind of scratch my head and going, why did you choose that particular number? Because it sounds good. It makes them look better and get closer to the whole 70% level. But yeah, that's the numbers we're talking about. So here's another one to make you eat your words, Carrie, about reporters. Okay. They are asking questions. They really are asking good questions. Just have to find it. Where'd it go? Maybe it didn't get in here.
Oh, then I don't have to eat my words.
Nope.
Which is fine.
Here it is. You do have.
Hi, everyone. Good morning. Thank you so much for taking our questions this morning. I do have a couple of questions regarding some specific numbers that I hope you guys can share with us. So the first one is, how many total number of cases in Ohio have been tied to the Delta variant? And then my kind of follow-up question to that is, can you give us an exact number of those who have a case tied to the Delta variant, a number of people who were vaccinated, and then versus the number of people who were unvaccinated, who had a case tied to the Delta variant? Thank you.
Yeah, I'm sorry, I can't give you those numbers. I don't have them immediately in my head. We can certainly share information about the number of tests that have been sequenced and have shown the Delta variant. We don't have any information that I'm aware of that would make the kind of specific ties, though, to a specific breakthrough case and a particular variant related to that breakthrough case. Remember, our breakthrough cases are vanishingly small. So the odds of being able to make such a correlation are very, very low indeed.
Bruce, for those who got on a little late, you might go quickly back through that description of the difference between the PCR testing and genomic sequencing and why we don't know exactly every case.
Oh, sure. So without repeating everything that I said, essentially what happens is that genomic sequencing happens after we have run a PCR test. It can only be done on a specimen that was drawn for PCR testing. Once we know that we have a positive PCR test, that's one that can be considered for genomic sequencing. And then only a subset of those can be, because either the specimen didn't have enough quantity or the viral load in that positive test wasn't high enough for the genomic sequencing to work. Then when we run that through, genomic sequencing, the time between beginning that process and actually having a formal, defined, and finalized result can be a matter of weeks. So we view genomic sequencing more as a public health surveillance tool rather than a patient decision-making tool. Because if we waited that amount of time, it's just too late. When we're making clinical decisions, we have to make them immediately. And we've, by that point, either been successful in our treatment or not.
Sorry, that was kind of my fault because I left it in one piece. I should have broken that down into two pieces there. But there you go. We now have the answer in terms of. It was a great question, wasn't it?
It was a fantastic question. I hope she asked a follow-up because so here's what happens. There's genome sequencing, and then there's variant identification. There are two separate methodologies. And you have to have the genome sequencing in order to know what the variant identification is, and vice versa. Some of the tests, the PCR tests, do evade a certain variant, certain ones, because if you have, I'm going to say, if the variant has caused a deletion on the 69th and 70th, or what we call 69-70 spike protein, and that deletion means it's taken it off. So when you test for that, that's one of the things that the test is picking up, and it can't pick it up because it's not there. It doesn't mean that you don't have it. It just means that it's gone from the original COVID because it's now a variant of it. In order to send a specimen for variant identification and genome sequencing, you have to have a positive test. You have to have a positive PCR test. You can't just send it because it sounds like a good idea. So, and we send those once a week. So every hospital or every lab in the state, if you come in tonight and you have symptoms of COVID, we're going to take a test, or somebody's going to take a test. I'm not going to take the test. And then tomorrow that we find out, oh, it's positive. Once it's positive, then those get batched, and all the hospitals or in labs send it to ODH every single Monday, unless the Monday falls on a holiday, then it goes the next business day, which is Tuesday. Then what happens from there, once it's sent, is ODH makes sure that there's 17 total state specimens. You have to have a minimum of 17 every single week. And if you don't, like say this week we only have 10, then next week you have to send your 17 plus the 7 that you were lacking from this week. Because there has to be, that's what we've been established by the CDC, per population is 17 specimens. I don't know how, there's a whole formula to it, but that's the rule. Ohio sends them. So ODH, they go to ODH. Then from there, they overnight them to, it's called Stat Lab, which is CDC and Atlanta. But it's a specific portion called Stat Lab. And then they start the process of genome sequencing, and then the variant identification. That process takes weeks.
That's what he said.
Yep. And the other thing is, so if it's a pooled specimen, so say there's a bunch of students and they're all getting tested, and so they're pooling them. So when you pool specimens, you're doing a bunch of specimens at once, then you can't use that. It says right on our instructions, we're not allowed to use pooled specimens. Well, Ohio does a lot of pooled specimens currently. So that's why it knocks us out of several that we can actually send, because they're typically asymptomatic if it's a pooled specimen. Not always, but typically there's a higher probability that we're going to have asymptomatic because we're pooling non-vaccinated people for specimens. And then you have to send it in a certain transport media. And if that transport media is not correct or acceptable, and there's a 3-ring binder that it has to be attached with, and there's shipping instructions, it's a process, then it's not accepted either. So it's always a good idea to send more than 17 because you might have 10 that aren't packaged correctly.
And
Right.
of course, we actually do have the answer to the question that she asked at some level, because you pointed this one out to me as well.
I don't
one here,
know how he doesn't have those numbers.
Well, it's right there. We're whatever 1, 2, 3, 4, 5, 6 from the bottom there. Ohio, the vast majority of ours are still B117. We are increasing genuinely in the B16172, the third column, which is our Delta variant. We're up to 5.8% out of a total of 361 available sequences over a 4-week period.
Right. So I guess we don't have any of the B1 351. So I guess my thing is where is this increase coming? Like, how is this the most prevalent variant?
Well, it's a question of, what they said actually in this particular press conference, and I didn't clip it, but what they he specifically talked about, it's not an overall large number, a large proportion. The Delta variant isn't a large proportion yet. It's increasing. It went from 1% of the sequenced cases to like 1.9% the next 2 weeks, and now it's up to, I believe, 15%. And then I think the last thing he said is in its preliminary data for the most recent time period, they're saying doubled the 15%. So they're saying, well, the percent, of course, whenever you use percentages, you always have to ask, well, what's our total number? What's our raw number? So yes, okay, so we have more Delta variant positive specimens of a very small number. That's 361 specimens that could be sequenced from the state of Ohio, and a whopping 21 of them were Delta. That's it.
Right. But if you look at the other ones, we have other variants that have more.
Yep. Well, he specifically did address that. He addressed it in the way of, well, when it comes into an area, then it will exponentially increase in terms of the proportion of the virus that is sequenced that then is the Delta variant.
But you
giving the impression that there's an increase in cases, but it's not about the increase in cases. It's the increase in the percentage of sequenced
or
variants.
identified, because
identified. Yep. Mm-hmm. So again, we're having this distortion of what's going on in terms of reality. We're given the impression that we are absolutely inundated with sick people, right? That the Delta variant is spreading everywhere, that it's exponentially rising in number. It's terrifying. We need to be scared. It's the unvaccinated who are at risk. Everything is
But how terrifying. Do we know that? Like, where is that data? Where, show me.
It's the studies, as he talked about in that last clip. What studies?
Yeah. Is it peer reviewed? Is it from humans? Is it prime? Because I haven't seen a lot of studies with a Delta variant. What are we talking about? The Delta variant.
The Delta variant.
Yeah, and vaccination. I'm like, I would love to have one. Oh, whatever. I would love to have a one-on-one with him. Like, can I ask questions? Is there a press pass that somebody can give me so I can ask questions?
I would love that. That would be that. I would pay a lot of money to get to see that. That would be so much fun.
It would be a blast.
Yeah. And actually, did you have something to say, Beth?
No, I said I want to be there for that too.
It would be worth it. So actually, this is one of the instances that I actually kind of this particular clip, the last of the things regarding Delta variant, that I actually do kind of respect Dr. Thomas for. He answers a good question. Where is it? There it is.
I'm curious to know, we talked about the trends, how they compare nationally and here, but with hospitalizations here in Ohio on the rise, are the effects of the Delta variant worse? What are you seeing from those recent hospitalizations? Does the Delta variant affect patients differently?
Thanks for the question. I think similar to Bruce's response, much of the data that we look at is data that's presented on a national basis from research scientists, the CDC, and others. At this point, I think we probably don't have a large enough N of patients yet that have been hospitalized with the Delta virus to really make any sort of a statistically significant assessment of just our patients here. But I think in general, the good news is that we aren't seeing a huge spike in hospitalizations, even though we're seeing this increase over the last really month, as Dr. Vanderhoff described, in the percentage of cases in the state that are the Delta variant. We're not seeing a doubling or tripling of hospitalizations. So I think the good news is that if you are vaccinated, you should be protected, at least against getting seriously ill or needing to be in the hospital. I think what's unclear is if you're not vaccinated, it's certainly easier to catch. That we know. We've described how it's more contagious. And I think that the reality is, even if it is not more virulent or causing more serious illness, the more likely you are to have it. Even if it's a small percentage chance that you're going to be in the hospital, the more people have it, the more people are going to be in the hospital. So I think that the studies are not showing that it's incredibly more virulent, or more serious as an infection. But what I will say, if you're not vaccinated, on average, compared to someone that is vaccinated, it's significantly higher risk to need to be in the hospital or to get severely ill. So I think it just gets back to the best way to protect you is to, one, not get the virus. But even if you come into contact with someone who has the virus, the best way to protect yourself is to be vaccinated.
Another good question.
It was a really good question, and I do give him credit for saying, we're not seeing it, and the reason why that's good, because that's real time. But so when we do genome sequencing and identification, our numbers are 4 weeks back potentially. If you look at that page that we put up, it's not updated every single day because we're only getting specimens once a week. Anyway, so that's going to be a lag time no matter what. But if he was saying, our hospitals are overrun, and then I could see, okay, now if the hospitals are overrun, then there's a higher probability that the next batch, we're going to see a huge increase. But he's not saying that. And I did like his wording. Kudos to him, as much as that is painful. I was not impressed when it came to Senate Bill 22 with him at all. But I will give him kudos because he did say, he used really good wording. If you are not vaccinated, it increases your risk. Well, duh. If you are not vaccinated, it could increase your risk.
And you also get tested.
Right, and you get tested. Yeah, it most certainly could. But of what? So, you're at a higher risk of what? And like you said, we don't know that yet. There's not we don't know that yet because he said there's not enough data to say. So, I will get, that's okay. He's got an okay half a star for the day.
So kind of in that same genre, and kind of a little moving on, talking about the hospitalization numbers. Again, this is I have to say, good on Dr. Thomas. I mean, I was not pleased with him early on, but he's pulling out some honesty bombs here.
I think in terms of hospitalization, which was one of your questions, we are seeing a slight rise over the past 7 days. I think some of that rise is most likely a small bump in cases coming out of the July 4th holiday that we're now seeing those cases become hospitalizations. But I think the reality is we've gone in our zone, zone 2, which is about a third of the state, from the high 40s of patients in the hospital the last week of June, first week of July, to the mid 60s of patients in the hospital. Now compare that to 1,200 patients in the hospital on our worst day back in December. So the numbers we're at now are where we were in about mid-June. They aren't unprecedented by any means, but they are on the rise. And what we don't know, as we've talked about with the press multiple times over the course of this pandemic, we hope that that rise will peak and come down, but we don't know that yet. And that's why we're certainly tracking those numbers on a daily basis and making sure that we're following the data and responding as best we can to be prepared for any surge of patients.
So we went from, and when he says region 2, we are not talking about region 2 out of 8 regions. We are talking about, as he said, a third of the state. A third of the state had how many hospitalizations did he
60?
say? It was like 64?
Yeah.
Yep, about 60.
Yeah, about 60.
Compared to our height of 1,200, for a third of the state, and we're talking Columbus area. We're talking about a major center of this, and this is what we are talking about. Again, he kind of drops off that truth bomb stuff. So I'm going to kind of like rush through a little bit more here because I would like to, double up on some clips.
Back.
Well, he said that on his own. That was during the main press conference thing. So apparently Dr. Vanderhoff invited him in, and that was his response to Dr. Vanderhoff and talking about it. But so this next section, I kind of broke it down. There's a couple I'm gonna do kind of back to back here about why we need to be afraid of COVID, specifically for our children, what they had to say about that.
That we remember that there's some folks 12 and under who can't get vaccinated right now. And we need to think about how we best protect them, because COVID-19 does affect people less than 12. And all we have to do is look at the cases of MIS-C, the multi-system inflammatory syndrome in children, to know that they're not immune from the bad effects of COVID-19.
So hold your thought, and let me add one more.
That right now, with what I've repeatedly described as a vaccine preventable illness, every illness we see, every hospitalization, every case of MIS-C, every long hauler, every death is one too many. It's tragic for us as doctors to see people get sick with something that we know is preventable.
It's one too many. So it's one too many for COVID, but it doesn't matter if it's, if it's a COVID vaccination reaction, then it's okay. It's expected because it's for the greater good. That's really upsetting. Right. As well as that MIS-C, which MIS-C is most certainly real. However, I'm still struggling between the MIS-C. Show me it's not Kawasaki's disease, because they look very similar. There is an actual test you can do for Kawasaki's, but not one for MIS-C. So are we ruling out Kawasaki's disease? And there's still such a few amount of kids that that's happening to. And Guillain-Barré syndrome and pericarditis and myocarditis and all kinds of horrible things, we're seeing an increase, but it's okay because it's mild carditis, which I still have no idea what that even means. What, you're still living? Is that why it's mild? I don't understand. But those things are okay. But if it's one of COVID and you're not vaccinated, we could have prevented that. Well, no, not necessarily, because the only thing that shot was designed to do was decrease the chances of you being admitted or ending up on a vent. It was to mitigate symptoms, not prevent disease.
So,
my TED Talk.
So in that perfectly set up vein, I am again going to have multiple clips kind of back to back. So write down your fury. Because there's going to be
as long as I can because I'm starting to we're getting a storm. And so if I'm dark.
We're almost done here.
Okay.
I'm going to put you out of your misery pretty quickly here. So that was about, how dangerous COVID-19 is. Now let's talk about the actual risks from the vaccine itself.
And while yes, there are potential side effects from vaccination, just like there are from any antibiotic or any medication, those risks are small indeed compared with the risks of COVID-19 for people of any age.
And let's do the next one. Hold those thoughts.
Could there have been vaccine-associated deaths? We believe that perhaps there have been some, but we're likely talking about a handful of cases. And that's going to be true of any medication, of any vaccine, of any intervention. The medicines that we provide our patients, the vaccines we provide our patients, are not entirely risk-free. They all carry risks, but their risks are tiny compared to the benefits that we offer. And that's why we as doctors offer them. The simple truth is the risks of these vaccines are tiny. The risks of COVID-19 are vast.
Got those things written down? We got one more.
Could there have been a vaccine?
If you look at two of the more recent complications from the vaccine that have been described in the literature, myocarditis, which we've known for many, many months you could get from the virus itself. And now there's been shown some cases from the vaccine. If you look at those relative rates, it was around 1 in 50,000 individuals who got the vaccine got myocarditis, was the estimate from the CDC. If you look at the risk of getting myocarditis from the virus, it's probably 1,000-fold higher, more like 1 in 50 or even potentially higher than that compared to 1 in 50,000. The one that came out, I believe, was over the weekend or just maybe it was Monday, around the J&J vaccine and the risk of what's called Guillain-Barré syndrome. They identified 100 cases nationally out of over 10 million, well over 10 million doses of vaccine given. When you look at it, it was interesting that the news story I was listening to reporting on it, the last sentence was, and the rate didn't differ that much beyond compared to people who didn't get the vaccine. Because you can get Guillain-Barré syndrome from getting bronchitis, from getting a sinus infection, from getting anything. Any sort of infectious illness can cause a very low risk of a serious complication.
So I just wanted to bring this up from Tuesday when we had our first Beyond the Data, this slide. And again, call up that we had, as of the date of the June 23rd meeting, and it was only data through June 11th, that we were talking about children who are at zero risk of anything, really. And we already had hundreds of people hospitalized with myocarditis. And I also wanted to juxtapose it to something I posted, I think maybe a month ago now, where I pulled up one of the studies that actually did look at myocarditis after COVID-19 infection, natural infection. And when they looked from December 12th, 2019 through September 30th, 2020, 42 weeks of data collection. They only could find 38 case reports. Now, 38 case reports over 42 weeks versus over 300 hospitalized kids. But these rates are negligible. Expected. This is just side effects that are, expected. This is like antibiotics. This is, the risk of bronchitis of after bronchitis. So we are amplifying Miss C, which could very easily be Kawasaki's disease, which
and that's bad too. Kawasaki's certainly is. I'm not.
Yes, it's
I'm
very
not.
bad.
Yeah, I'm not mitigating that at all. But I think that's the problem with what they're doing. In the name of COVID, we will amplify, but we will not validate or acknowledge those injuries that have occurred for those people. Hear them, let them be heard, and they have nothing to fall back on. The difference between other vaccines and antibiotics is not only is it full disclosure, you can go to any pharmacy wherever you pick up your medication or talk to your physician, whatever, and you're getting a lot of information. You can Google it, and there's a lot. It'll say, warnings and side effects on it. But with these, as we can see, there's not a lot of people still that are well versed in what can and is happening. And not aside from that, is there is no vaccine injury at this time because they're under EUA. There's nobody to hold responsible at this time. So I feel like that is comparing apples and oranges. Yeah, it's an mRNA. Yes, it's a EUA vaccine, biologic, whatever we're going to call it today, but it's not on the same level as something that has been out. And, again, we have the vaccine injury, which that's not easy either, but we're only looking at these. Right. It is so hard to do a vaccine injury for any vaccine, but then an EUA vaccine to associate it with it, it is very, very difficult. You have a greater chance of not being able to associate it because, one, they only look to 14 or 21 days past the second one to include that as a vaccine injury. And even with death, I had talked several times about that. This is the first time we have a template, a rubrics of an algorithm to follow for a death if they're vaccinated, and if we need to look at a vaccine induced death, because I've never done genetic testing to see if somebody had a clotting disorder, and when they never had a clot before, they expired from multiple clots, and the only thing that was induced differently was the vaccine. But if they do have the genetic predisposition and that testing comes back positive, the cause of death is not the vaccine or a vaccine reaction. The cause of death is the unknown underlying clotting disorder that came positive. And I think that's awful. We've never done that before.
Yeah. And like I said on Tuesday, I mean, you've got a vicious cycle. If you are genetically predisposed to any kind of disease that has a negative process that is a result of inflammation, which a clotting disorder would be one thing that could be, where if you have the genetic predisposition, you encounter the vaccine, which causes insane amounts of inflammation, which then turns on the genes that otherwise would not have been touched if you had not had this insane inflammation. And so you end up dying from the vaccine, or at least having this disease, and then it circles back and says, well, you had the genetic predisposition.
Right.
Even though without that intermediate step, it never would have happened.
Shouldn't we be looking at that before that we give, if that's a concern, shouldn't we look at genetic predispositions before we say we're Governor Mike DeWine and make a blanket statement and say, hey, these are safe and effective for everyone?
Mm-hmm. All right. So I'm going to leave all this stuff on kind of a good note here. I'm going to let the doctors say one thing. Thomas, again, I have to give him kudos, because he's really improved what he's saying, and I really appreciated what he said in this one last one from him. Where is it?
I don't know.
That group from age 0 to 12. Obviously, that's a group that's not able to be vaccinated now. I really applaud the CDC, the FDA, and the vaccine manufacturers to make sure that they are, double checking all their numbers before moving lower than age 12 for vaccinations, given that younger people tend to tolerate the virus better. I think the benefit case for vaccination for those individuals is a little bit less than someone who's 80 years old.
Okay, a quarter of a gold star. We're going to average it out to a quarter of a gold star because, he did say I'm not really sure. And I think at the end of the day, that's what we all need to look at. I don't care if it's Bev in a long-term care facility, me doing whatever I do, Kathryn doing, whoever it is, you have to look at a benefit and risk assessment for yourself and your loved ones to see if this is something that I need to do or something that I could benefit from.
It's on you.
Right. That's just that's just my personal opinion, but I think we've gone so deep because we've for months heard safe and effective for all, safe and effective for all. Yes, go line up your elderly and your neurodegenerative and your immunocompromised. It's safe and effective for all. And now here we are and we're like, ooh, maybe we need to pull back on that and wait about 5 years and see. But if you really want it, we will give it to you. Of course, it's available. It should always be available if somebody feels strongly for it, because they know their risk but benefit more than what I do. But it may not be right for me. But 0 to 12, I don't have kids that age. I love kids in my life that age. But I just don't think we are there yet because we don't have that long-term data that we really, really need. And to mandate it, yeah. Bev, in the nursing home, and you don't have to say which one because I know that you are at many or have been throughout this pandemic. Did you see any increase post-vaccination?
In the facilities? No.
Okay. Did you see any increase of any neuro changes?
No, only because I get floated from unit to unit. I'm not consistently on one unit all the time. So whenever I work, I never know what unit I'm going to be on until I get there.
Okay. That makes sense.
Yeah, unfortunately, there's no sense of consistency with anything in that regard. But, every facility is having the same problem because of the staffing shortage. So
what is your staffing shortage like?
Any day we get a lot of agency people that are coming in that absolutely have no idea any of these patients, and they're just kind of going through the motions. And, sometimes the best that they can do is make sure that they get the medications that are ordered.
Okay. So
being able to assess one of them is very difficult when you don't know what their baseline is already.
So that's a difficult thing. I wouldn't have even thought about that.
Right.
Okay. Well, we have a lot of healthcare that follows Kathryn's page. And I know that they've been extremely concerned about the vaccination and just challenges in general that they've experienced over the course of the last year. So, or year and a half. So I just didn't know, especially with you having that different flavor of different facilities and different units, if you had seen or experienced other than getting sent home after being exposed to chip. That was the best one. So, yeah. And you had already been in the facility for how many days?
11, because he was tested 11 days prior to me transporting. I went to work that same day, and halfway through my shift, I get a phone call from my very good friend Carrie saying, hey, by the way, we just got the results back from Chip's COVID test, and he was positive. And silly me, I had to go and make sure that my supervisor, being the diligent and responsible person that I try to be, I immediately contacted my supervisor to say, hey, this just happened. So what do we do?
And they sent you home for how long?
Well, what they told me that could be as few as 3 days, but full 14.
After she had already worked, and it just didn't make any sense. I'm like, when did we stop learning how to count? This doesn't. What are they doing? And you've already been there. How many days in a row did you have to wear the same mask?
Oh, jeez. I think I was wearing that mask until it smelled like nasty sweat socks on my face. Probably, I think we were supposed to wear it a minimum of 2 weeks initially, but if you can make it last longer, please do so, because the only way you're going to get a new one is if one of your straps breaks. So mine was going on 4 weeks because I didn't, unlike some of the other employees who would intentionally break theirs so they could get a new mask. Mine didn't break, so I just kept wearing it. But obviously it wasn't going to protect me from COVID. So after that 3 days being exposed to Chip, who tested positive, if I wasn't already showing symptoms by then, I should not have had to be out for the whole 14 days.
Yeah. And that's an N95 that they were given like a paper bag. And she was like, here's my mask. And I'm like, what are you doing? Like the OSHA and JCO and me, like my eye was twitching.
We should probably take that particular conversation about OSHA and all of these situations to another one. And my
we
internet
were
is
just
getting
waiting for you to come back.
Oh, I've been back for a while.
Oh,
I assume
okay.
it's here,
I want to see if we're ending on a good note. I want to see this video that I keep seeing on. Or I haven't seen the video, but there's a lot of chatter on social media.
So there was this great moment in, and I think it's appropriate in what we're talking about here, where it's nonsense and what kind of ridiculousness. I think the reporters are starting to get it, and I think this reporter probably lost his job.
Down for you the essentials of how it works, because I think it's important.
Dude, the guy's wearing a bow tie like Ducky from NCIS. That's great.
What we'll be talking about today is...
That is the best thing ever. Ducky from NCIS. He is now Dr. Ducky. Like, I will never be able to call him anything beyond Dr. Ducky.
I'm
Ducky from NCIS.
Science guy.
Yeah.
So yes, that really did happen in the press conference yesterday. Some reporter did not have button on, and it was the second time.
That is fantastic. Dr. Ducky from NCIS with his bow tie. That's epic.
I thought I'd end that on that great note where it's like, you know what? The reporters, to hand it to them, they've gotten better.
Shannon's right. Ducky was smart. Yep, I did like Ducky. Ducky was smart.
He was.
Well, yeah. It's Ducky's.
Oh, but it was fantastic, Dr. Ducky. Oh,
thank you to the people who managed to hang on through this.
We appreciate it. Sorry for earlier, and we will get better eventually. Maybe not.
My internet will improve.
Yeah, and thank you, Bev.
I don't know what is wrong.
Yeah, a little more advanced heads up would have been good.
I just needed a person, so I wasn't just standing there like. All right. Have a good night, guys. Thank you. All
right. Good night.
Good night, everyone.